Thank you for the opportunity to speak. I'm actually a second-year medical student at UT McGovern Medical School in Houston. And so our study was the safety of robotic-assisted laparoscopic repair for recurrent paraesophageal hernias, insights from a large single institution experience. And I don't have any disclosures at this time. So minimally invasive laparoscopic repair represents the gold standard right now for paraesophageal hernias. However, when looking at laparoscopic repair for recurrent paraesophageal hernias, there's associated with increased perioperative complication rates, worsened outcomes, and increased conversion rates. At the same time, we've seen an increased use of robotic techniques for gastrointestinal surgery. However, with regards to paraesophageal hernia repairs, according to literature, it's kind of unknown in terms of what role robotics plays. So, as you probably are aware, there's advantages for robotic technique, 3D visualization, there's wristed instruments, decrease in hand tremors, ease of suturing, and then obviously decreased surgeon fatigue with the console. When we looked at the literature for robotic-assisted laparoscopic PH repairs, we found those largely consist of small single-surgeon or single-center experiences with patient numbers being from 4 to 126, and the vast majority being on the lower end of that. So our objective, our aim was to compare the outcomes of patients undergoing robotic-assisted laparoscopic repair of recurrent as opposed to primary paraesophageal hernias. For our methods, we had a single institution retrospective review from 2009 to 2017 of adult patients who underwent robotic primary and recurrent repairs. If the patient had a simultaneous weight loss surgery, then they were excluded from the study population. So here are some of the variables we looked at: demographics, use of mesh, estimated blood loss, intraoperative complications, conversion rates, operative time, rates of leaking, hospital length of stay, reoperation rates, recurrence, dysphagia, gas bloat, and then PPI use. And for our analysis, we did a Pearson's chi-square test and Fisher's exact test. So we had 265 primary repair patients, and then we had 60 recurrent repair patients. We looked at the age, BMI, the ASA score, the gender distribution, and the pre-op PPI use, and we found that there was no statistical difference between the two groups. The average age was in the 50s, BMI was under 30, the ASA score was around 2. The majority of them were female, and then the majority had been using PPI use prior to surgery. So the patient populations were very similar. There were no differences in marital status, insurance status, or race and ethnicity between the two groups. And then, as expected, for recurrent repairs, you had more previous abdominal surgery and obviously more previous PH repairs. So we then discovered that with recurrent repair, there was a longer operative time, 170 minutes versus 137. There was a longer hospital length of stay with 66 hours versus about 44. And then you were more likely to have a mesh placed, about 50% patients having mesh versus 34% for primary. We also looked at the fundoplication type distribution, and we found that the majority of those patients underwent a Nissen fundoplication. And then we also looked at the type of paraesophageal hernias for the patients, and the majority of them had type 3, although there was also type 2 and type 4. And then there were no conversions or esophageal leaks in either group. So far, the results have been pretty much exactly what we would expect with recurrent patients, as they tend to be more complex on average. So we looked at the mean duration of follow-up, and we found that that was just under a year, and it wasn't statistically significantly different between the two. Additionally, we looked at the intraoperative complications and postoperative outcomes, and so complication rates, estimated blood loss, readmission rates, recurrence rates, and reoperation rates were all, there was no statistical difference found between the two groups. And when you look at the numbers, they're very similar, if not almost identical. We also looked at the dysphagia, the gas bloat symptoms, and as well as use of PPI on the last follow-up. And again, there was no statistical difference found between both groups. And again, the numbers are very, very similar there too. So to conclude, although associated with longer operative times and hospital length of stay, which we expected with more complex patients. They actually had similar perioperative and postoperative outcomes when compared to primary paraesophageal hernia repairs when you're doing recurrent. So this suggests that there's a possible role or advantage for using robotics when doing repairs for recurrent paraesophageal hernias. However, obviously there are more studies that need to be done in order to determine whether or not these outcomes are secondary to the advantages that the robotic platform offers, or whether it's due to other variables like length of follow-up or surgeon experience. Thank you.